Thank you. Our next speaker is Professor Aung. He is the director of the Singapore Eye Research Institute and the deputy director of the Singapore National Eye Center, a world-renowned figure researcher in the field of primary angle closure disease. And he'll be giving his first lecture on anterior segment imaging in angle closure.
Thank you very much, Tanuj. I'd like to thank Tanuj for the invitation. And I'm giving two talks, actually. The first one on imaging, and the second one is on Ming Guang He's talk on how do we manage primary angle closure suspects. So I come from Singapore, and unfortunately, there's a coronavirus outbreak, a few cases in Singapore, so better avoid me in the break. Yeah. So you heard from Dr. Tanuj as well as Dr. Siota about angle closure being a different disease from open angle glaucoma because the angle abnormality is the primary mechanism, and we have to make the right diagnosis by assessing the angle correctly. We've also heard a nice talk by Dr. Tanuj about gonioscopy and how important it is to visualize the angle structures. And really, you know, people make gonioscopy very complicated, but the primary aim of gonioscopy is to determine if the iris is opposed to the trabecular meshwork, and if there's apposition, means that there's contact, and this could prevent aqueous outflow, and this is angle closure. And then, of course, you have to distinguish between appositional and synechial closure. Although gonioscopy should be performed in all patients, we also know that many doctors don't do gonioscopy, or they're not familiar or not confident of their findings. And there are also some issues with gonioscopy, particularly that is subjective and observer dependent. It varies according to your lighting conditions that you use, as well as how you do the gonioscopy and the type of lenses. And of course, you have some training required. So let me give you an overview of anterior segment imaging on how it can be used to supplement your gonioscopy and your angle to make the diagnosis of angle closure. So basically, you can use UBM or OCTs. Let's start with UBM, and UBM is a very useful instrument to look at the angle. It gives you a very good resolution, and importantly, it can look at structures behind the iris, such as the ciliary body and the choroid. And so it is a nice way of looking at the angle, but the problem is that you need a good technician to do the UBM, and sometimes it's not so easy to do it, and it can take a bit of time. So in a busy clinic, most of us cannot order a UBM for every patient. OCT has been around for more than 10 years, and just like in the retina, it is a non-contact way of looking at the angle, and the older device was the Visante, and now we have the Cirrus. So I think Zeiss has stopped selling the Visante, and now they have a Cirrus, which comes with an external adapter, so the retinal OCT can be used for the anterior segment. And similar images are obtained by both the Cirrus and the Visante. So in the OCT, the problem is you need to have some kind of a subjective analysis of the image to determine if there's angle closure or not. And really, you have to see, is there apposition between the iris and the angle structures, as in this picture, which is very obvious. But one of the problems with OCT is that in most of the cases, you can't image the trabecular meshwork, so we have to guess where the trabecular meshwork lies. And it's easy, practically, you follow the inner line of the cornea and the sclera, and where they meet is the scleral spur. And we know that the trabecular meshwork lies just anterior to the scleral spur. So this is the landmark to use to determine if there's angle closure on imaging. So here, for example, you can follow the inner layer of the cornea and sclera. They meet here. So this is the scleral spur, and there's obvious iris contact anterior scleral spur. So you assume that that's where the meshwork lies, and this will be a case of angle closure. In some cases, you can't tell. So for example, here, it's all smooth, and there's no like a indentation or reflection point, and then it becomes a little bit difficult to tell. In Singapore, we're interested in automated grading of these images, and rather than trying to be subjective, because some of my clinician colleagues say, "Ayo, I don't know how to interpret the images, can you help me?" So we have developed like a machine learning algorithm to automatically tell in green if it's open, or in red if it's closed. So this is a way that we think will be helpful for clinicians, but this has not been adopted yet by Zeiss. We can also make measurements of the angle, but really, in practical terms, we don't have time to do it in our clinic. And anterior segment OCT is also useful because we can able to look at structures and make measurements of anterior segment structures. For example, the iris, and we found that this is an independent risk factor for angle closure, the iris thickness and area, the anterior chamber area, anterior chamber width, and as Dr. Seota mentioned, lens vault. So lens vault is, in some cases of anterior angle closure, the lens is very big, especially the anteriorly jutting into the AC. And these cases will need a lens extraction. So this literature shows that angle closure is not a homogeneous disease. There could be some different mechanisms in different patients. And as Dr. Seota mentioned, we've looked at whether there are subgroups of angle closure patients based on anterior segment imaging. And in Singapore, we found that there's one group with a thick iris and one group with a large lens vault and a small anterior chamber. But most people have mixed mechanisms in which it's difficult to tell exactly what is the main mechanism. It's probably a mixture of anterior segment as well as lens and involved. So we brought this forward and tried to develop an algorithm to look at various measurements to see if you make all these measurements, can it improve your diagnosis of angle closure compared to gonioscopy? And we found that you can do it with an AUC of 0.95. So this could be potentially useful as well from 6 anterior segment OCT parameters. And we then developed an automated way of doing this, and we compared it to our, as I told you earlier, our earlier automated machine learning device. And we just published this paper last year where we compared these two deep learning systems to look at angle closure detection, the single scan or compared to the multiple measurements. And we found very similar results, which was surprising. Sorry. So in the two studies were very similar. And in fact, the single scan was good enough to help us in making the diagnosis. Let's move on to the Swab Source OCT, and this is a newer OCT device, and this is made by Tomei by Casia. And this also can obtain high-resolution images of the angle, as you can see here. But what is useful about the Swab Source is they can do a 360-degree view of the angle, and this looks very nice, but this scan is not that useful clinically. But the scan that I like to use is this one, where you can see here, in this arrow going around, the Casia takes 128 cuts of the angle and then reconstitutes this in a video. So what it does here is that it takes in 1 second multiple cuts. You can see the yellow arrow going around of the angle in 360 degrees. And then it then comes out with the output like this. So basically this is what it does. It takes 128 cuts, and so you can see 256 angle images. Now, the Casia has an inbuilt system of measuring angle closure called the ITC index, but this is very complicated, and it needs you to mark out the scleral spur, so we don't use it normally in clinical. And what we're trying to do is we've developed a software to look at all 128 scans in parallel. So what it means is that our software will measure open, close, in all 128 scans, and then gets a composite of the 256 angles. So here's the software in action. And so basically what we do is that you open up a patient, and here's a patient being selected. And then you run the scan here, process. And here, as it's going in the percentage, it's going around and measuring each angle at a time to assess open, close, 128 times. And then it will then come up with the output within about a couple of seconds to tell you how much of the angle overall is open and closed and where are the areas of closure. So here's the output here. So here it'll tell you overall about 37% is closed and 63% open, and where are the areas which are closed. So I think this is something quite more useful for the clinician in practice with the Casia. The Casia can also be used to look at PAS imaging, as in this very extreme case. And again, Chris Leung from Hong Kong has published on how you can use the Casia to do PAS assessment. But I think in most cases in our practice, we don't need to use Casia. You can just do it clinically. And here's a patient with a pre-op angle closure with lots of PAS and after phaco goniosyncytialysis. And of course, as in any other technology, there's now a hyper-parallel OCT that's being developed, and this is by Sci-Light. And we're right now we're working with it, but I don't really see many advantages of this device compared to what we have at the moment. Finally, about angle photographic methods, there's a NIDAC has an angle photography method where it's like a light contact in the eye, and it takes a 360-degree angle photograph, as you can see here, and then you can then look at the angle photograph. So, but really, it's a new device, and we don't know how useful it is for. It's a way of imaging the angle with a photographic method. In Singapore, we've tried to develop a cheaper device called a gonio pen, and this is something like a very light contact next to the slit lamp device, which you can attach to the eye, and you can obtain images like a gonio photograph, but it's without any bright light. So this is another cheaper way we think it can be produced for a few $1,000s. So I think in summary, there are different methods to image the angle, and as I said earlier, each method has got advantages and disadvantages, and there are ways of looking at it to help you to image angle closure. Probably is useful in patients to document the angle closure. You can show the patient what the patient has, they understand what is happening, and also it can be useful to look at changes over time. And I think for us, I'm trying to develop ways to make it more automated and easy for the clinician to use without much interpretation. So I'd like to acknowledge here my colleagues who work with us on angle closure. Thank you for your attention. So let me move on to the second talk, which is on Ming Guangxi's